So good afternoon, everyone. Thanks for being here. This is session 4 of the healthcare track of the Gazette's Iowa Ideas Conference. I'm your moderator. I'm Vanessa Miller. I've been covering higher education for the Gazette for the last decade. I've been here for 12 years. I've been covering healthcare more recently as well. And I just want to note this Leadership Roundtable, like all of our sessions, has closed captioning available and also is being recorded. I just want to start by thanking our sponsor, which is ITC Midwest, for this panel. And again, I want to thank everyone for being here. So I guess I'm going to start by just having our panelists introduce themselves and talk a little bit about their tenure in healthcare and connection to it, and then we can jump in with questions. I also want to note that if anybody who's watching or listening and has questions, you can go ahead and shoot those to our moderator, and she will give them to me, and I can ask them of our panelists as we go. So you can do that at any point throughout the session. So yeah, we can just start with you, Sandy, if you would.
Hi, my name is Sandy Deckhirsch, and I'm the Executive Associate Dean at the College of Nursing at the University of Iowa. I've been at the college since 2007, and before that I worked at the University of Iowa Hospitals and Clinics in pediatrics.
Great, thanks. And then Brent, yeah, go ahead.
Hi, my name is Brent Willett. I'm the president and CEO of the Iowa Healthcare Association. We're a statewide trade association that represents post-acute healthcare providers in 99 counties and about 275 cities and towns. So we represent nursing homes, assisted living programs, home health agencies, medical directors, hospice agencies, and a number of other adjacent groups at our association, and work to provide advocacy training and clinical service delivery to our members, again, across the state. Happy to be here.
Awesome, great. Yeah, and then go ahead, Michelle.
Sure, thanks, Vanessa. Can you hear me all right?
Yeah, we can hear you.
All right, I'm still working on camera. I'm having a little trouble here on my end. It looks like it's on my end, but it is apparently not on yours, so we'll keep working at that. But thanks for having us here today. Thanks to the Gazette for sponsoring this conference. So I'm Michelle Mearman. I am fairly newly the Chief Operating Officer of the East Division for Unity Point Health, which includes our hospitals in Quad Cities, Waterloo, Dubuque, Cedar Rapids, and Madison, Wisconsin. I previously served as the president for Unity Point Health Cedar Rapids, was in that role for about 4.5 years, but had spent the entirety of my healthcare leadership career there, starting as an administrative resident back in 1994. So I'm happy to be with you today.
Yeah, great. Well, yeah, so I thought it might be helpful to just start by kind of doing looking a little bit at the landscape of healthcare in Eastern Iowa and Iowa as a whole, or the region too, and just kind of where we were before the pandemic, what some of the main issues and challenges were at that time. Does anybody want to jump in on that? What about you, Michelle?
Sure. Sure, I can start. It's almost hard to remember sort of pre-pandemic in some ways, kind of some of the trends that we saw prior are things that were really sort of accelerated by the pandemic. And in our prep here, some of the questions that you asked us to think about, Vanessa, kind of foreshadowed that. But, variety of things here, right? So I think aging of the population is a factor for all of us in different ways, just in terms of what that means from sort of a chronicity and complexity of illness perspective, certainly a consideration. There is also, for those of us in healthcare organizations or systems, there's a financial impact of kind of changes in the demographics and the payer mixes of our population. So even pre-pandemic, I would say we were seeing some downward pressure on revenue, while at the same time caring for these more complex and chronic patients. I think pre-pandemic we were feeling like we're seeing some kind of workforce strain. When you think back, sort of pre-pandemic, that's by comparison, it's significantly different during the pandemic and subsequently. So definitely something to talk, more about as well. So those are a couple of the things that I would say, not similar sorts of issues, certainly in retrospect, a much more stable, period of time than what we are currently facing, much more volatile environment in many ways today than years ago.
I can follow up with that from the educator provider point of view, that we were definitely hearing about a nursing shortage that was coming and the need to prepare, more nurses, thinking about the acuity of our patients, but also in the state of Iowa, the exodus of young people. So who would be stepping into those roles, and how would we keep people here in the States? That's definitely been exacerbated by the pandemic. So people that may have had 5 or 6 or 7 years more, left in them to retirement, had some decisions to make, after they've, I would say, survived the pandemic along with everybody else in the practice environment. The need for nurses in the hospital is certainly great, but the needs for nurses in other places where individuals receive care is even greater. Keep in the hospital, they also are leaving long-term care. The level of education of nurses at the different types of facilities differs as well. We know that the more education that a nurse will get, the better care that patients are, on average and in aggregate, are going to have. So, some of the places in the state that are most needing of nurses are also losing their young people to want to stay in the state, and they are the people who are working in the hospitals and long-term care and the other care environments that we have here. So I would say we knew that was coming, and it's exacerbated by the pandemic for sure.
Yeah. Well, and one question I sort of had is thinking sort of similarly to like 9/11, everybody talks about sort of post 9/11, how there were things that were just forever different and were a new reality. And I'm wondering if there are things in healthcare that are that new reality post pandemic. Like, what are things that maybe changed and that is just now the new norm and the new reality? Maybe it is just that there was sort of a mass resignation and we're dealing with things like that, or traveling nurses. Maybe that's a question for you, Sandy, but things like that. What are we looking at today that's different?
Well, I could, there's certainly some externalities from the pandemic that are deeply challenging and negative. There are some positive things I think we learned. It's kind of like how in the outside the healthcare space, kind of like how we learned that working from home worked as well as it did. It's kind of a miracle if you think about it. We learned a lot about essentially by force what innovations in care delivery work and what don't during COVID. So during COVID, we had a myriad number of waivers that were implemented by the Centers for Medicare and Medicaid Services to address the situation in hospitals and clinics and nursing homes and other settings. I can say, particularly from a long-term care perspective, we specifically learned how well telemedicine delivery worked for certain applications, particularly in the home and in nursing facilities. In Iowa, we've just seen the Department of Health and Human Services make permanent waiver modifications for home health telemedicine delivery. That was something that we called for because we learned we had such a positive experience and in addressing the devastating workforce shortages that we've been talking about. And so I think there's certainly some things that we were that we accelerated our discovery on and have found that they really work. Now, telemedicine delivery in nursing facilities, those waivers came off. They have not come back. That's certainly something that we're advocating the federal government to take another harder look at. But there are some positive things as well.
Yeah, absolutely. It does feel like there were some nice things that came during the pandemic, and like you mentioned, would be nice if we could continue them. Maybe we can continue them on some fronts too. And I'll note that I think we're trying to get Michelle back. She may have fallen off, but we're working on that. I have a question here that I'll throw to you both. It says, can any of the speakers comment on other challenges that nursing staff, other than nursing staff, such as losing so many physicians across the state and risks of losing hospitals, clinics, care centers across the state? Are there like sort of staffing challenges that are threatening hospitals? I wonder if that is what's meant there.
Yeah, I mean, from a long-term care perspective, we've seen close to 30 nursing homes across the state close in the last 24 months. That is the culprit for the vast majority of those closures has been an inability to access enough of a qualified workforce to care for the residents in the facility. I think we can anticipate more consolidation and further closures of facilities across the state as they battle for workforce as Sandy made mention, from a diminishing population of able-bodied workforce aged individuals, and so I think it's causing it certainly causes a lot of challenge in local rural communities when these sorts of things happen. But also it forces us all to face the reality that the healthcare delivery system, at least, and again, I come really from the long-term care perspective only, that we have grown to come to expect that if we need to receive facility level care in our elder years, that we're likely to be able to access that pretty close to home. That's changing in Iowa, and I think that trend will continue to move in that direction.
I think in addition to that, there's we're seeing this conversation, amongst our state legislators, as well as the need for women's health and OB, care, mother baby care, and psych mental health care. And so, we're seeing across the state critical access hospitals being closed, and I guess to Brent's point, this consolidation, so people have to travel further to get the care that they need, but in their immediate environment, when it's an urgent need, it's not there. So I think that directly reflects the fact that you don't have physicians, nurses, and all the other people there taking care of people. But when the facility closes, so go the people that are in those facilities. So I think that also should make us think about how people practice, and having nurses and PAs and physical therapists and others working to the top of their licensure, so that they can give care that may be maybe not there because you might not have as many physicians. And so that can be very complementary, care that allows for a bridge for patients to receive care immediately, and then to get to maybe one of the larger metropolitan areas to, if they need to be transferred. But I think we really have to be looking at the people who are here, and are they practicing their trade to the top of their licensure?
Yeah, that's really interesting. I mean, and when we're talking about long-term care needs, are we talking primarily about nurses, or are there other practitioners that there are shortages in?
Great question. There are shortages up and down the healthcare workforce continuum. Nursing homes in particular employ a lot of certified nurse aides, or CNAs. LPNs are also practiced fairly heavily in nursing homes in Iowa, and there are challenges in terms of shortages for those positions. And really, when you look at a long-term care setting, whether it's a nursing home, assisted living, care continuum community, those are real ecosystems of a workforce, because these are places where people live. And so not only do we have medical professionals from CNAs to medical doctors, we also have housekeepers, we have groundskeepers, we have operations and maintenance individuals, dietary managers, dietary workers. So it's a very comprehensive, densely, when done well, it's a very densely packed workforce with a lot of people caring for each individual resident up and down their needs path.
Yeah, right. And maybe either of you can't answer this, but I'm just curious. Like, I wonder if this is a regional thing, or is this a reality nationally, that this shortage is happening across the healthcare workforce?
Yeah, it's a reality nationally. I mean, long-term care workforce is down more than 250,000 people nationally since the advent of COVID. That's about 8% in Iowa. The number is a little bit more dramatic. We lost 12% of our workforce in long-term care as a result of the pandemic or since the pandemic. And we have only recovered 2% of that. So we're still down 10% from pre-pandemic levels. But this is a national issue, and I'm sure Sandy can speak to it from a nursing and other space.
Yeah, I would agree. It's a national conversation, and I don't know if we want to move into sort of the preparing people for these roles, but when there's a national shortage of nursing or any kind of healthcare provider, there's a national shortage of the educators as well. So I don't even know. I don't know who's first, the chicken or the egg. It's a classic kind of conversation about that. But you don't want to be taking people out of the workforce where they're so desperately needed, but we need people to teach too. And so one of the challenges that we have is creating models where especially nurses, because I know that world might have dual appointments with a health center wherever care is being provided, but also with an academic center or place that's preparing nurses for the profession. Because it's just you don't want to, I guess, rob Peter to pay Paul or whatever that is, right? But you need instructors. You're not going to get more students if you don't have teachers. So we walk that sort of tightrope all the time. And in order for us to even increase the number of students that we'd have in our programs, we need to increase the number of instructors we have, and we need practice sites for them to do their practicum hours in. So we spent a lot of time working with care facilities, long-term care facilities, hospitals, any place that people are being cared for, to build relationships so that we can have our students in there doing their practicums. Data shows that when they have a great experience in those practicums, they're likely to stay in that facility if they're offered a job as well. So
yeah, absolutely. And because I have heard that the students are there. I mean, in terms of applicants, are students willing and wanting and interested in doing it?
Yeah, we enjoy that at the University of Iowa. I can't say that that's true of nursing programs across the entire state, but we very much have a healthy supply of applicants to our undergraduate nursing program. And I would say close to half, maybe not quite half, stay in the state of Iowa. And our applicant pool tends to be, our graduating pool tends to be about half from the state and half from outside of the state. And you've asked me about traveling nurses too. And so before the pandemic, that was a thing that we were seeing. Certainly, I've been teaching since 2007. In the last year or two, this is the first time where we ask students, what do you want to do when you're finished? And traveling nursing is a destination. Most people would have said, I want to be a peds nurse, I want to be an OB nurse, I want to work in the OR, I want to work with older people. But they're telling us, I want to be a traveling nurse. I think that that's a generational thing. They're not unlike their peers who want to be mobile and want to travel and experience other kinds of environments. The pay has been better for these students. They have a lot of debt, many of them do. And so you can see why it is appealing for young people to want to do that. So I think we have to get creative and figure out, what can that look like? And how do you also at the same time respect the nurses who are in your healthcare system that are not making that same salary as a traveling nurse? You got to have some balance there. And maybe we create better systems that you travel within a system instead of outside of a system, or you give people a leave and then come back in a year so that you don't totally lose them. But it's a generation of employees. And so I think we're going to have to work with it.
Yeah, I mean, I am curious, Brent, like, are traveling nurses a pretty common thing within the long-term care centers?
Yeah, we did see an explosion of staffing agency utilization during the pandemic. I can say that since July 1st of last year, in long-term care, staffing agency utilization has declined by about 25% across the state. So it's starting to, staffing agencies have been a part of the healthcare delivery system for a long time.
Yeah.
Kind of always have been, always will be. I think we got fairly disproportionate during the pandemic for a lot of reasons, and that created serious patient care challenges along with financial challenges for providers. And the Iowa legislature acted in 2022 to enact what we call fairly common sense regulations around staffing agencies to ensure that we know who they are, that they are sending facilities, hospitals, and clinics licensed, credentialed individuals for the positions that we're asking them for, a level of transparency around what those individuals are being paid versus what the margin of the operating margin that they're the total margin that the agency is taking off of that pay, and a really important prohibition on non-compete agreements. We were seeing some really sad stories of individuals who were recruited away to work at staffing agencies, signed a lot of paperwork and didn't necessarily realize that they'd entered into a non-compete agreement and were not able to leave that agency back to their previous employer. So that kind of thing's not, again, now not legal in Iowa, and so things have gotten a little bit more back to normal. But I think that Sandy makes a great point. We got to meet the workforce where they are, and there are a number of really innovative agency models out there that make working in healthcare maybe more accessible, more feasible for individuals with complicated lives. And we want to make that kind of thing available. We just need to make sure that it intersects and interfaces well with the overall care delivery system, because as we have folks that are not familiar with our systems, maybe not as invested in the residents as the permanent staff, it's going to be an ongoing challenge.
Yeah, and do we have you now, Michelle? Just want to check in.
I am still here. Can you hear me?
Yes, I can hear you. Great.
Okay. Yeah, I would like to add maybe just a couple of thoughts to what Sandy and Brent had to say there. I think that whole notion of meeting people where they are is really important, and I think all of us in our as healthcare organizations, delivery systems, have tried to work even harder with our college partners, be they our colleges and universities or community colleges. And I think, a couple of things. I do think there are untapped populations that have perhaps not considered healthcare as a field that is open to them. We've not seen people that look like them in our field, just have found us perhaps not as welcoming or as understood. So we have, I think, a lot to do as healthcare delivery organizations and colleges and universities to reach out more broadly within our communities, our neighborhoods, to help find people who could be very successful with us and have wonderful careers, contributing their strengths and talents. I think it's been very interesting, working again with different colleges and universities just to see what the challenges that students face are. Sandy, of course, knows that far better than I do, but just having done quite a bit of work, for example, with Kirkwood, and seeing that for many of their students, it's not so much a matter of tuition, because there are many kind of opportunities for that to be offset, but these are people with families who have to take time off between semesters to be able to pay the bills and feed the kids, and so they need a different kind of support, and they need a different kind of support when they come into the workforce. So there's plenty of opportunity for, I think, the collective us, both educational institutions and healthcare delivery systems, to think differently about how we attract and how we support people who haven't traditionally thought out or sought out healthcare as a field.
Yeah, I mean, it does feel like a pretty tricky balance between what a hospital might want, which is to pay its staff nurses, the rates that it has been paying, versus a higher rate for travelers who don't have the institutional knowledge, and that makes it more appealing. I mean, I can see some of the challenges that are facing the institutions. And I guess I'm wondering, when it comes to travelers, does it do you hear anything from patients or from the people who are receiving the care that there's a difference in the level of care, and is that a concern at all?
I would say generally not. I mean, I think that, within, the organizations that make up the organization I'm part of, we've been fortunate to be able to have our travelers, by and large be a number that they're part of, a care team. They're not making up the entire, care team on a given unit or in a given department. So you're able to wrap around people that are, abundantly, familiar with all of the processes and the problem solving and the like. So when you're able to do that, I think you can very much look to provide, that same experience. But it's not easy, it's I think one of your questions, Vanessa, was how do your non-traveling, your regular staff feel about it? Well, it's a mixed feeling, right? Because of the comp differences. On the other hand, we need the help, so there's that, kind of balancing of, kind of feelings that you have. Do you need more hands or, to be stretched further? So it's definitely a tough issue. I would, note Sandy talked about the concept of, health systems developing their own, travel pools, for example. That's something that the system that I'm part of has done, and so your flexibility in being willing to travel to, 3 Unity Point hospitals or 12, makes a difference in terms of, how you can be compensated based on that kind of level of flexibility and so forth. So being really creative in that way, I think, is an important part of, again, kind of meeting people where they're at and, meeting the needs of the organizations and the patients we serve as well.
And students tell us too that, they don't want to lock in and say, well, I'm going to be a med surg or an OB nurse or whatever for the rest of my life. They actually really like the, I guess, the thrill, the challenge of like having a lot of different experiences before they really settle down and say, this is the kind of, this is the type of environment that I can see myself in for a really long time. So I think even more innovative would be to create these models, right, where they might be experiencing long-term care, acute care, primary care. I mean, nurses are needed everywhere. And one of the things that we are looking at in academia is a switch to the essentials, the essentials that speak to what are the competencies that our nurses need when they finish our programs. And that's how we are accredited. And we are seeing a shift from not being so focused on just hospital-based care, but care that's in primary care settings, community-based nursing, where people live long-term. I mean, those are all places that, need nurses. So, trying to provide that rich experience for them when they're in school is one thing. They get a short, 8 weeks, 6 weeks, whatever it is, but some of them desire that experience when they come out of school too. And as they're practicing and, and bringing in a paycheck. So I think there's some, pretty exciting, fun things that we can do, given that we know that this is what motivates this workforce.
Yeah, and you mentioned something just there that I had heard was part of maybe the shortage. Obviously, there have been people who have stepped away, especially during the pandemic, but is there also just like an increase in need for providers because they're in more spaces? Like they're not just in hospitals anymore or clinics, but they are in like office places or more like care facilities, or I mean, are there just more healthcare providers being hired across the region and country?
I would say yes. I mean, I don't know that that's a brand new trend, here necessarily post pandemic, but as Sandy said, I mean, you see growing applicability in the clinic or the ambulatory settings. You see when we're talking about nurses in particular, you see roles like case manager, care manager that crop up in insurance companies or governmental programs, that rely on the thought work of nurses to help, guide care and decision making. So yes, I would say, probably over the last 20 plus years, there have been far more options, many of which are not, as we might need in Brent's, side of the industry or mine, many of which are not 365, right, 24/7, which is great for people, challenging, then in terms of being able to attract talent. So yeah, definitely a little more optionality for folks these days.
Yeah. Yeah. And maybe this is a question for you, Michelle, but I just was curious about, or whoever, I mean, if you guys can speak to it, but whether there has been, whether there was sort of a pause in people receiving healthcare or going to get preventative care during the pandemic, and how that's affecting the healthcare landscape today, whether it's like, in the emergency room or elsewhere.
Yeah, there's been a variety of things. I mean, I think there was definitely, sort of during the height of the pandemic, kind of the start, March 2020, probably well into 2021, where, if people could stay away from hospital sites of care, they did. I probably myself, put off a, mammogram for, a while. There was no reason to do that. But, I think it's kind of two pronged. Some people were nervous, about being in those care environments. Others just didn't want to overburden, kind of a strained system, whatever the reasons might have been. So I think, there was probably a good period of 12 to 15 months where people did defer care. And, that means, by extension, that there were things that might have been caught earlier that were not caught until later, in terms of various kinds of forms of diagnosis. I think that we're getting to a point where that preventative care is probably largely sort of resumed, but, still seeing some of the burden from sort of the delayed diagnosis and identification. And again, just, it was going to happen anyway, but with the aging of the population, the number of Medicare beneficiaries, again, that just, it's kind of like that's really, really catching up to us, I think, at this point, as a healthcare system. So, that complexity, that chronicity is really a factor for us in a lot of different ways now.
Yeah, that makes sense. And that has been what I've heard. When we're talking about some of the like business piece of healthcare, and folks are coming, to receive care, and I know that the demographics are shifting across the state and region. I mean, are care centers, clinics, hospitals being faced with doing more charity care? I mean, is that affecting budgets in any way, or can you talk at all about kind of like the financial challenges right now, in addition to just like staffing needs?
Sure. So in long-term care, more than half of the individuals receiving long-term care are on Medicaid, which means that they're not able to afford their own medical care. Medicaid's a system that has historically been underfunded, and it creates significant challenges for providers in being able to service as many Medicaid residents as we really need to. The Iowa legislature, Governor Reynolds, have injected significant funding into the Medicaid system for long-term care over the last few years. Mm-hmm. It's helped quite a bit, but as costs continue to rise, I mean, and that's also affected by the workforce situation. So in Iowa, last year, 3 out of 4 nursing homes were limiting or stopping admissions because of an unavailability of staff. Mm-hmm. That has significant down or upstream effects on the rest of the continuum from a hospital discharge standpoint, mm-hmm. et cetera. So we see the trends as we not only are aging, we're seeing a higher and higher utilization of individuals utilizing the Medicaid system, which sort of underlines the necessity of making sure that creates solvency possibilities for providers.
I'd just note kind of a, sort of a interesting intersection, there with something Brent just said. We're all also connected ultimately to one another, sort of as a, not very systematic system of care. As just a anecdote, last week, St. Luke's and Cedar Rapids on one particular day had greater than 20 patients who were through their acute course of care, but there was not skilled nursing or nursing home placement available anywhere. And so those patients, are still in need then of our care, perhaps at a slightly different level, right? Because they've made their way through their acute needs, but they're still with us. They're requiring care, they're taking to bed, which then means that if someone from a critical access hospital calls to say, I need a bed for a level of patient that I can't take care of, it's then difficult for us to accommodate that. So it all ties together and it's just been much more evident, I think, in sort of this era of, lesser availability of staff, lesser availability of physicians and the like. But back to your original question, sort of on the, sort of the financial pressures and business sustainability, I would not say that the number or percentage of sort of uncompensated care, charity care, as the industry sometimes refers to it. I would not say that is increased substantially. There were certain protections kind of in place during the pandemic period to kind of keep folks on the Medicaid rolls and so forth for the type of care we deliver. So that was helpful. But I would agree with Brent. Medicaid has been fairly traditionally underfunded. Again, I also agree that there's some relief on the horizon there that should help. Medicare, again, we're seeing our number and proportion of patients who are covered by Medicare increase. That is also not necessarily, from a business perspective, going to be one of your strongest payers, either. So you are, again, seeing that downward, kind of pressure on revenue while you're seeing this upward pressure on expenses. And, if you don't have sufficient staff and you can't take your volume, then you're not covering your fixed costs, so it's definitely a challenging, kind of time from a financial sustainability perspective.
I'll add to this conversation just a little bit. There's also plenty of people who can pay for their care, but can't access the care when they need the care. So I think, we have to pay attention to that. And again, it really speaks to the fact that we could have some really innovative care models. So you can have two working parents and the place where they need to go for primary care is not accessible to them when they're able to take their children to care. So they're going to go to the ER after hours and things like that, or a urgent care facility. And every time we sort of fragment the care that takes them away from their primary care provider, you put in another provider and an increased cost of delivering care. So I think that there are, again, if I go back to one of my statements about, leveraging practice models that really take advantage of people's practicing to the full capability of their licensure, and who is it that we're providing and where is care being provided. There is room for innovation and room for people who do and can pay for healthcare to access it where it makes sense and is most it's like what do I want to say? I don't want to say economical, but it's not displaced and they're not getting a more expensive care when that's not what they need. I don't need to take my child to the ER for the flu. I need to go to a primary care provider for that, but if I can't access it, I have to pay more. It's a more expensive for everybody.
Right. Yeah. I guess, and I'm wondering, because all of these do seem like, universally challenging. Are there any in issues everyone's facing? Are there any like Iowa specific things that you think this state or this region is facing when it comes to some of the healthcare challenges and issues today?
Well, it's mental health and OB maternity care, and I think that we're going to see the legislators paying attention. I mean, I know that they are, and I hope that we're going to see some, we're going to see more resources and more thought given to those two areas. I mean, it's a given we're an aging state, so we're conscientious of that, and long-term care and caring for people 65 and older, but you don't want to do that and forget the fact that you also have families of childbearing age, and that you have children, and that you have, productive working people that, need their health optimized so they stay in the workforce. So I don't think that we're that much different than other rural states when it comes to mental health and paying for and looking at maternal health. I mean, that's a national problem. The national statistics on the health of moms and, our infant mortality rate are not where they should be, given the type of nation that we are. So I think if they have to be healthy, we're not going to have healthy elders if we don't have healthy kids and healthy, um, adolescents and young people in the workforce.
Yeah, I mean, that does make me wonder though, like can any of you speak to what is maybe behind some of that OB deficit? Like why we're facing struggles in terms of providing enough care or high quality care when it comes to maternity issues? Is it that Iowa is more rural and people just aren't near the kind of care that they need, or is it staffing?
I don't know what's come first, but again, it has to do with, the closing of primary care and some of these critical access in smaller hospitals in the rural areas. When you close those things, then you lose those providers in the community. So again, the further you have to go for that type of care, or even for, delivery, the likelihood that you're going to have an acuity that becomes something that could have been managed and not gotten to that level of acuity if it were delivered closer to home, it's just going to happen more and more. But there's a lot of we as a nation, we don't necessarily emphasize prevention, and so that plays into the maternity care as well. When you close those kinds of centers and you don't have the prevention piece of it or the well person piece of it in place, it just makes that problem even worse.
And I think I would just add to that. I mean, I think it's, almost I'm not sure how to describe it, a bit of a paradox, or, I think that part of the reason that you see some of our rural communities perhaps no longer having an OB service is because their volumes of deliveries have declined over time. And much of that just relates to migration of population. Iowa's not getting bigger, and Iowans are migrating from rural communities to urban ones, and therefore those numbers go down. And to credit good intention on the part of those small hospitals, they become concerned about their ability to consistently provide high quality care when their numbers are low. Yeah. But the paradox part, right, is I think Sandy pointed out the other half of that is that when then there is no OB service, your primary care providers say, well, there's not an OB service at the hospital, so I'm not going to do OB care. We'll have to go elsewhere for that. And then that just spirals the challenge, right? Yeah. So there's, there's a variety of, there's some other factors I think as well that go into some of that decision making to not have an OB service in a rural hospital. But I think that's part, in Iowa at least, I wouldn't say that this is, true of sort of the maternal, health crisis nationwide. I think there's, other equity sorts of issues at play as well. But that's part of what happens here. There are, I think, a couple of demonstration projects in different parts of Iowa where we're trying to, find ways for a provider base in a rural community that does not have an OB service in their hospital to partner with, someone who does, so that you can build out that continuum of care, differently to make sure that that good prenatal care is provided and that there's a plan, then for delivery. So there are things we can do, and this is one of Iowa's many good features. We're small enough that we should be able to figure out how to work, together to bring resources to bear to address
I think those are excellent points, Michelle. It's so multifaceted, right? That's why I was kind of like, well, I don't know, it's kind of a chicken and egg thing. I don't really know, but with those things become great opportunities too for innovation and to, work differently. So.
Yeah, I guess that kind of makes me think too. Now, this is like a little bit tangential, but I'm curious because so many people have been talking about artificial intelligence and how it's going to change all the things. I mean, is there some sort of staffing help or solution there when it comes to healthcare, or is that not? I mean, people still want to talk to a doctor, obviously. I mean, what sort of, I don't know, technological help could artificial intelligence provide on this front, if any?
I'm no expert in artificial intelligence, but I will say, and I think we talked about this a little bit earlier. Brent, I think, mentioned it, some of the things we've learned during the pandemic. I mean, I think we're better and stronger with telehealth. We talk now about something at the beginning of my career, never would have, thought I'd heard the words virtual nursing, so how do you have a nurse who's participating, who's somewhere virtual, help support the education and discharge process for a patient who's, in our setting achieved, kind of the outcomes of their acute course of care. It's time to go home, but needs kind of a deep dive one more time in their instructions. And a virtual nurse can cover that while the, on hands, on-site staff are able to go about the cares that need to be provided to the patients who are in a more acute state. So I do think, maybe not specific to the notion of artificial intelligence, but just the evolution of technology and how to really integrate that in our care settings is really important. Among the problems there is it's capital intensive, or can be, kind of at startup. So the ability, for folks that are, organizations that are strained already to kind of maximize that is a tough thing to do. But yes, I do think, technology can, help us advance.
Sure.
Yeah,
What
I think,
right,
I mean,
yeah.
long way to go before, I think it's likely it's a long way to go before we see that kind of technology deployed for actual patient care. But I mean, there's a lot of innovation and adoption happening now down the sort of the care continuum in a long-term care facility. Lots of long-term care facilities today are experimenting, for example, with robotic dietary carts. So these are relieving individuals who are currently running meals out to dining rooms for residents, and that's actually a fairly complex process because of the medical and meal needs of a long-term care resident. It's not a matter of just kind of a serving line, and so there's some dietary, some food companies that are experimenting with these kinds of things. I think that's where this kind of thing starts, is we're looking to relieve pressure, workforce pressure, in less medically intense environments. Housekeeping is another example where there's some things going on there. So I think that's probably where we start, and then having this conversation 3, 5, 10 years from now, I think is when we start talking about real, the potential for real patient care delivery of robotics and artificial intelligence.
Mm-hmm. I think it's going to help us a lot with cultivating data and aggregating it so that we can make better decisions, or what's the right staffing mix? What's the right group? You cannot, it's just almost humanly impossible to take in all the factors that influence a decision or how, an organization functions. So I hope to see it used in partnership rather than in replacement of, and being, again, I think to Brent's point, that the things that it does replace, like jobs, are the things that then relieve people to do the things that humans can do and should do. And no one's ever going to replace human touch and compassion and the things that people who are needing care need. But tools that help us with things that can give us more time to do those things, or help us make tough decisions, or again, put data together so that we can create smarter systems are good things.
Yeah. And what about from the training perspective? I mean, we talk about how we need so many more educators to get nurses into the hospitals and clinics. I mean, could technology help us get more people trained?
Yeah, we're already seeing this. So during the pandemic, we, had to appeal to the Iowa Board of Nursing, as did every state, to look at, contact hours versus the hours that students were spending in clinical simulation. And so there are some studies that are coming out that, in some cases it was better. It was not worse than being in a practice environment. You can't be exclusively one and not the other, but it certainly is giving students the opportunity for more repetition in a shorter period of time, and to experiencing things that we can't possibly cram into a single, into 2 years of nursing education. So the simulations that we can create are more realistic, more diverse. And so they're learning to work with people that they may not experience at this hospital, and in situations that I never had to think about, like disaster situations or pandemic situations. So how do you train your workforce in an environment where they stay safe? I mean, it's threatening to, send students into a place where they too could get very sick, and then we don't have a new nurse, right? So it's definitely going to help us be able to train students, and is helping us train students now.
Yeah, absolutely. And we are kind of coming up on the end of our time, or getting near it. But I did want to ask whether, to all of you, whether there are certain like policy or regulatory changes that you think might help you address any of the issues that you're facing, or make things a little easier, to expand care, to provide care to staff. Your hospitals and clinics and care facilities.
Sure. I mean, probably in two different directions. I mentioned earlier, kind of at the top of this call, there's a tremendous opportunity for the federal government to make permanent a lot of the telehealth and telemedicine waivers that we learned worked during the pandemic. It was a disappointment that the administration allowed those to expire. There's certainly an opportunity to do that. I applaud the state, the Department of Health and Human Services, not only for making permanent those telemedicine waivers that they control at the home health level, but also their orientation and investment toward more expansion of home and community-based service delivery in Iowa. We're standing in partnership with the department there. I would say that they're from a long-term care, particularly nursing facility standpoint, there's a existential regulatory threat today that the federal government, CMS, has proposed a federal staffing mandate for skilled nursing facilities that would require, under penalty of fairly ruinous fines, the hiring of about 2,700 more people in long-term care facilities. I can tell you that every nursing home in Iowa would hire more staff if they were available today. The reality is those 2,700 people today just don't exist. Mm-hmm. And so this is a fairly ham-handed regulatory proposal by the administration that we're trying to fight back against. Really what it means, if this rule were in place today, nursing homes would be forced to discharge about 3,500 residents that they're currently caring for in order to comply with this regulation. So there's some opportunity, and there's also some bad ideas out there, and it seems to be always the case in healthcare.
Yeah, absolutely. And I do. So I guess I will ask, I mean, we have kind of seen a lot of discussion, especially in this region, of late about closures, consolidations, things like that. I mean, and you talked about this a little bit already, Brent, but what is the threat there of losing actual providers in this area, and what would that mean for Iowans if we aren't able to sustain the level of variety in healthcare that we have right now?
Yeah, I mean, there's, I don't want to raise alarms, but there's a tremendous threat of further nursing facility closures based on the availability of a qualified workforce, based on the ability to identify the next generation of owners and operators for these facilities, and making sure that we have a process that works for them to work through the transaction process and ensure that those facilities remain open. And it also is significantly impacted by the the availability and I should say the percentage of individuals who are needing this care, higher and higher acuity needs with a Medicaid system that has seen significant improvements, but we're seeing residents in nursing homes and assisted living programs and in the home health setting who are younger, who have higher acuity needs, who are more medically complex, a skyrocketing level of substance abuse challenges, which are lifelong challenges for young people. And something that's particularly devastating is the younger and younger demographic of individuals who are needing care with cognitive challenges, which will affect their livelihood. So that's a long way of answering your question, but those local nursing homes, when they close, what that means, not only are people out of a job, not only is access in that community impeded, it means that the individuals, most importantly, the individuals receiving care in that facility have to be moved. And transfer trauma is something that is a very real thing. These are people, if you're in a nursing home today in the United States of America, you're very, very medically fragile and very medically acute. And the physical transfer from one facility to another is incredibly challenging and often creates more medical complexities for that individual. So it's fairly devastating up and down the continuum whenever a nursing home closes.
I would just add to that. That was so well said, and I think that there's probably just room for dialogue among all of us, right? Because if our nursing home sector is struggling, that place, as we talked about earlier, that places maybe an unexpected strain on your rural or your urban hospitals, which then pushes your strain to your academic medical center. So I mean, we all have to I think over time kind of enter into probably different levels of dialogue with one another about how we strengthen one another, because I think ultimately we want to all try to take care of Iowans as close to home as we can. And if any segment kind of weakens, it just gets more and more difficult to do that. So, I don't have specific, kind of regulatory, recommendations. Funding is always an issue, particularly in some of those areas that we've talked about today. But, that kind of opportunity for dialogue and sort of all of the parts of our industry, I think is a good thing for us to consider for Iowa.
Yeah, and I think the last question I'll ask, because we are now almost out of time, but we didn't really even talk about mental health and the increases there. But I just wanted to ask, I mean, is that part of the pressure that's being placed on the system? Is it because I've just from my higher education reporting, I've been hearing that mental health needs are increasing. Is that part of the increase we're seeing at the hospitals, clinics, care centers?
Yeah, I think absolutely. From a couple of perspectives, I mean, I do think we are making some progress in sort of reducing stigma, so that people are a little more willing to talk and to seek care, and they're doing so. And there's not enough, kind of care availability there. Either payment parity remains, and payment availability generally remains an issue, I think, across, sort of the mental health part of our worlds as well. So yeah, that's absolutely a factor and part of the challenge.
And I would add to that when the mental health care needs are not taken care of, the other physical needs of people go up as well. So I mean, it's well documented that often they have multiple comorbidities, or when you have a challenge of your taking care of your brain health, then you might leave your diabetes out of control or other things that you just don't have the energy to care for. So, it's a holistic approach to people. So you just really can't have one without the other.
Yeah, absolutely. Well, thank you guys. I think that takes up our time today, but I appreciate you and all the panelists and all the participants for listening in. I'll just note that the next session on the healthcare track isn't until tomorrow morning. So at 8:30 a.m., there's a session on preventative care. Everyone's welcome to that or any of the other sessions. So thanks again for for being here, and thanks to our panelists for your thoughts. It's very valuable. We appreciate it.
Thank you for the invitation.
Thank you.
Yeah, thanks.